Hello, everyone. Thank you for joining today's webinar, Beyond the Buzzwords, Creating Employee Health Benefit Solutions Using Innovation, Collaboration, and Strategy. This webinar is sponsored by Nova Healthcare Administrators. Over the last 30 years, Nova Healthcare Administrators has evolved into an innovative health plan solutions company that uses flexibility and creativity to improve holistic, self-funded health plan performance and build a better experience. Every situation is unique. Healthcare solutions should be too. Nova focuses on creating a solution that is both personal and personalized to better serve and support clients and their members. Nova administers self-funded medical, dental, and vision plans, COBRA and reimbursement services, and private labeled solutions for approximately 500 clients with nearly 250,000 plan participants. I'm Sean Edwards from World Congress and Validation Institute, and I will be introducing today's webinar. Just a few announcements before we start. I'd like to explain how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our speakers, please do so using the Q&A feature at the bottom of the screen. We'll answer all questions that we have time to address during our session today. Finally, please feel free to contact our presenters if you have any additional questions. Please note the webinar will be recorded. You'll receive an email with a link to the video so that you can view it again. Now I'd like to introduce our speakers from Nova Healthcare Administrators. Jim Wallishauser is a president, Teresa Vincent is a product manager, and Todd Martin is the chief sales officer. And now, without further ado, I'd like to turn things over to Jim to get us started.
Thank you very much, and good afternoon, everyone. It's really a pleasure to be here with everyone today. I'd like to talk a little bit today about strategy. And first, to begin really talking about strategy is really what we do to help our clients build their plan and strategy. We like to think of Nova as it's more than just a TPA. We definitely understand that our clients and their members have unique healthcare needs. So we don't approach our clients with a predefined solution or boilerplate services just because that's all that we do. We have base services, but we also have a toolbox full of capabilities to help customize these solutions. We seek to understand the individual needs of our clients and their members. In turn, we create innovative and customized solutions and plans for the health of our clients and that of their entire member population. So how do we do this? Well, a few ways. First and foremost, I must mention culture. Culture really is everything. A healthy and vibrant culture to meet the needs of our associates provides a solid foundation to ensure that we can meet and exceed the needs of our clients that we serve. We want our clients to visit our organization, and even during this time of the pandemic and working remotely, there are ways that we can do that, and ways through technology we can accomplish that. We feel that's very important because we feel we're an extension of these organizations and our core values that define our DNA. Our Nova family shares a passion and purpose for servicing our clients and members. And we employ what we call a stewardship model to ensure that we build the right services and support structure for each of our clients and client partners. In addition, we value our strong broker relationships, as together we're able to extend the reach of Nova across the country. Over time, we've worked hard to build and solidify the foundation and infrastructure and base services supporting the multiple lines of business, whether that's traditional self-funding or back office or level funded products. And now we're seeing the growth of direct primary care along with our reimbursement products and services. Internally, we are structured via strategic business units, or what we like to call SHIPs, supporting these lines of business and clients, providing for a more personalized and high-performing service model. I like to look at this as a 70-30 type model, where we continue to provide the base traditional services which are foundational, like claims processing and customer service, but we continue to focus on elevating these services like care navigation to support and create an overall better experience in helping our members navigate the complexities within the healthcare system. By understanding these populations that we serve, we're able to better understand their healthcare needs and the needs of their members, and we work to develop specific programs and services that target these needs. We focus on outcomes. We do that through data analytic capabilities, our population health management capabilities, our infrastructure and system integration capabilities, partnering and creating strong vendor partnerships to extend those capabilities. Our goal really is that of the triple aim of better access to care, better quality care, better affordability of care, and focusing on those outcomes. And now we're able to even work on the quadruple aim with our partners and our ability to work with direct primary care and providers. We're able to help improve overall provider satisfaction and vitality. So in summary, our strategy really is to help our clients build a customized strategy and plan to meet their specific needs and that of their members. So with that, I'd like to turn it over to the next section with Teresa Vincent to talk about innovation.
So we are going to do a poll before we move into the section on innovation. So we will have that pop up in just a moment. And the poll question is, how often in the past year did you base your decisions about benefits or point solutions on data provided by your partners, on return on investment or other key metrics such as health indicators? And the options are always, mostly, sometimes, rarely, never, or I want to, but I am not sure how. So please take a moment, make your vote. We'll give you about 20 seconds, and then the results will pop up on the screen, and we'll talk about innovation. Okay, so it looks like the top answers are mostly or sometimes, with sometimes edging out just a little bit. So what we want to talk about in the next section is how we use innovation, how we use data to drive innovation in our organization. So innovation is one of those words that gets thrown around a lot. It's something that everyone says they want in their organization. It's something they want in their health benefits. It's considered this very desirable thing. But are you actually getting the right kind of innovation? Are you just chasing something because it's shiny and new, or are you getting something that you really want? So a really simple analogy about what constitutes good innovation is, say you go to your favorite diner, you want to get yourself some lunch, and you go in there, and what do they have for lunch? They have this great new innovative sandwich. So you say, I want that innovation, that's going to be delicious. And you get it, and it's a grilled cheese sandwich, but with the cheese on the outside and the bread in the middle. It's innovative, but is that really what you want? No, it's going to be a mess to eat. It's not going to be what you wanted. So you have to make sure that you're asking the right questions at the beginning of the process so that you know what you're actually getting. We always think innovation is thinking outside the box, but it's actually not. Sometimes it's really just looking at what you already have and making it a little bit better. So if we can move to the next slide, then I have some key questions that you just need to think through when you're moving forward. You want to ask, what is the actual problem you're trying to solve? Sometimes you want something because it looks great, it seems really cool, but does it really solve a problem? Does it really enhance anything? Or are you just doing it because that's what everyone's talking about in the industry? Just because it's a trend in the industry doesn't mean that it's something that would necessarily fit for your business. And have you performed a root cause analysis of what the problem is? Sometimes when we think we know the problem, we just see the surface level of the problem. And then you really have to dig down deeply to find out what is the actual root cause. And Todd, when we get to his section on collaboration, is going to give you a great example of how that looks. When you don't do the root cause analysis, you could solve the wrong problem. You have to know, are you solving the right problem? And what are your goals? Do you have short-term goals of, say, we have to cut costs for this year, we can't add anything extra? Or are you looking at maybe long-term goals, if we can invest more now to get a better payoff down the road? So you really have to look at the bigger picture and what is your roadmap to get where you want to be. That's what real-world innovation looks like. That's something that you can make really functional and that integrates really nicely into your organization. You know, innovation is a function of thought leadership, which is really desirable. It's something that, you know, you want to have smart people around the table making good decisions, but, you know, if you don't have actionable insights, then you're still kind of operating blind no matter how good the innovation looks. You need to know what tools you need to actually be successful. So we'll click to the next slide. I will actually give you a real-world example of post-discharge outreach. So when a member goes in for inpatient services and they are released from the hospital, they get discharge instructions. And sometimes these are complicated. They're not easy for the group to follow, for the individual to follow. But in groups, that can actually lead to really high costs, because what if someone gets readmitted? What if they go back into the hospital after 7 days or 14 days or 30 days? So we took a deep look into our readmission rates, and we've provided intervention through our disease case management and utilization management services. We have a dedicated team at NOVA that really digs in on these medical cases and tries to improve the health outcomes. It's not just about lowering the cost, it's actually about improving the health of the individuals that we serve. So you will see our average for 30-day readmission rate is 8.11%. And you might be thinking, well, that still seems kind of high. Well, the national benchmark for readmission is about 13%. So we are actually 5% less than what the national benchmark is for 30-day readmissions. And that is because we have this tailored outreach. So we make sure we're checking in with people when they leave the hospital. Do they understand what their instructions for their discharge plan? Do they know what to do if something comes up that's worrisome and they may need to go back to the hospital, or they just handle it by talking to their doctor? So within 7 days, it's down to 3.72%. At 14 days, the readmission rate averages 5.05%, and for 30 days, it's 8.11. And that's our average. Where we have actually been able to intervene most successfully with readmissions, we've dropped it down to 2.48% for a 30-day readmission rate. That is real money, and that's real health back in the lives of employees that can go back to work faster, that can stay at work healthier, that can actually get more done in their lives and in the business, because they don't have to worry about going back into the hospital. They are able to use their discharge plan to actually rebound from whatever put them in the hospital in the first place. So this is our example of how you can really tailor programs that actually impact health, impact costs, and really drill down. We could have looked at that 8.11% average and said, well, we're 5% better than the national benchmark, so we're good. But that's not really what you want to do. You want to keep digging until you get to where you know you can be the best you can possibly be, and people are the healthiest they can possibly be. If we could move to the next slide, it's actually going to be 2 clicks to the next section. The other really important thing in innovation is sometimes just rethinking your process. So when you're doing things that do outreach for disease management, case management, that sort of thing, they can look so good on paper. You can have the most beautiful plan. You can have a vendor that you work with that just has all the bells and whistles and everything you would want for a member. But if they're not engaged, it doesn't matter if it is the most perfect solution that has ever been created. So a good example of this is we actually had a program where we would reach out to people for case management. And we would call them on the phone. We would try and reach them and say, hey, we want to talk to you about case management. We want to connect you with somebody who can personally walk you through your care plan, answer any questions you have. But people weren't answering the phone. So we changed the process. And if you click again, you'll see another graphic pop up. What we did was we went from just doing phone calls to inserting a letter in the process. So we would have 2 phone calls. We would have the letter. You click the slide one more time. Then we would call. So people would get the letter. They would know why we were calling them, and they started answering the phone. The great thing about that is it was a really easy fix. It was just looking at the process and figuring out where the gap was, and it drove really substantial innovation and engagement with our group. So innovation is not the new thing. Sometimes it's going back and making what you're already doing the more efficient thing, the more effective thing. So it's not always bringing on a new vendor or going out in the marketplace with some big new solution. Sometimes it's just doing what you do really well and modifying what you've got. And then the next example that we have under innovation, if you'll click to the next slide, and one more. I think it's going to be one more after that. So we have this disease management team, and diabetes is a significant issue in the population of this country, and it is something that we pay a lot of attention to. It's very expensive, it's very hard to live with, it's a serious chronic condition, it can have all sorts of complications. So we had a situation with a member who was diabetic. She was not doing very well. Her A1C level was 8.5, and we thought our disease managers, all trained nurses, really specialized in providing this care, thought that she would really benefit from an insulin pump. So our team called the member and said, we think you would really benefit from having this continuous insulin pump. And she said, well, it costs too much. I would like to have it, but I just feel like it costs too much. It's not worth it. So the disease manager walked her through why that was actually a better option for her. And she decided to go forward, get the insulin pump. And within 3 days, her insulin usage dropped 70%. 70% from what it had been only a few days before for the small investment of cost. And her A1C within 3 weeks had dropped from 8.5 to 7.1. And she started counting her carbs, taking her disease management much more seriously. She lost 14 pounds in 3 weeks when our disease manager went back to check up with her. So she saw in a very short period of time a huge return on this investment in her health. And she didn't stop there, this member. She actually went beyond that and became an advocate for other people within her company that may have been experiencing the same problems and that may have experienced the same benefits from getting an insulin pump. So she actually went to her human resources department and explained what had happened to her, how we had helped her get the technology that she needed to improve her health. And then she became an advocate for other people so that they would be able to afford the insulin pump that was so beneficial to her. So this is really showing that it's not just one person taking action in the past. This is an entire ecosystem of people that are all working together. We do it in the framework of strategy that Jim talked about. We have a lot of data analytical people on our team. We have a lot of really smart healthcare professionals, nurses that do outreach, that do this all day long, that can provide really personalized, really precise care. And in a moment, Todd's going to talk about how we collaborate with our outside stakeholders and show you how we build this entire spectrum of services that is very responsive. We're able to provide really precise, personalized care because we have this strategic infrastructure, we have our culture, as Jim mentioned, and then we're able to go in really deep and understand what's really happening with our population, whether they're here where we're located in Western New York, whether they're in Utah or Omaha or wherever. That is something that we are able to do because we have great collaborators. And with that, I will turn it over to Todd Martin, who will talk about our special relationships with our collaborators.
Yeah, thanks, Teresa. I appreciate that. So to try and build on what Jim and Teresa spoke of, is that there are so many shiny new toys being spoke about and being presented across the industry. How do you really know what is the best shiny new toy for your client? It really all comes from understanding the population through collaboration of the broker, the client, and truly the data. I want to share a couple of client scenarios on how we've been successful in really implementing those shiny new toys to improve outcomes, but all while controlling costs for some of our clients. I think that every broker or consultant at some point has experienced emergency utilization abuse, right? So what is the shiny new toy to combat that cost driver? Well, it really depends on why people are going to the emergency room. So if you can get that information, that's really important in developing the strategy. Sometimes you can see that there's emergency room utilization, but you don't necessarily know why. Typically, historically, you would just change plan designs, right? So most people historically, if they see that there's emergency room abuse, they'll increase the copay on the emergency room, maybe decrease it on the urgent care to really just steer utilization based upon plan design change, which, that's all great, that works. I think it does help to some point, but, we really feel that that's treating the symptom, and not necessarily the root cause of why people are going to the emergency room. A couple examples that I've always been fond of is, we brought on a new client that had many more dependents than what we traditionally see in a population, and I don't think we really thought that much of it. Within the first 6 months, we saw that emergency room utilization was off the charts from what we typically would see. When we dove down into the data, we found that the population that was utilizing the emergency room all the time was actually new moms. So what comes with a lot of dependents? Obviously, new moms. And it was these new moms utilizing the emergency room, say every time little Johnny would cough or sneeze 24 hours a day, new moms, they're scared, rightfully so. They'd run to the emergency room as that first line of defense. with this population, we implemented a 24-hour nurse line so that this could be the new mom, or really anyone for that matter of fact's first line of defense. We did a targeted outreach to new and expecting mothers to educate them on the 24-hour nurse line. Let this be your first resource. Let this be your line of defense to talk to an RN for free any time of the day. Let the nurse know what's going on with Johnny. What are the symptoms? Maybe it's something simple like go to the pharmacy, get some Dimetap. Maybe it is go to your pediatrician in the morning. Maybe urgent care, but very worst case scenario, emergency room. If it's an emergency need, we obviously want to get that dependent there as soon as possible. But at the end of the day, this was a unique cost driver, and what was driving that emergency room utilization, which many moms, would probably act in the same manner. So by laying some groundwork prior to little Johnny coming into the world, some targeted messaging, we were able to avoid emergency room utilization moving forward. Same cost driver, but a different client. This one was actually dependence as well, but it was actually dependence between the ages of 18 and 26. So for any of you parents that are out there, there's probably a lot of 19-year-olds and 20-year-olds that still have mom take care of everything for them. But in this situation, mom can't make a doctor's appointment. So these 18-year-olds, some of them may have been away at school. Some of them had aged off of their pediatrician and didn't know how to pick up the phone to make an appointment themselves. So every time they got something simple like strep throat, bronchitis, they needed a $5 prescription like a Z-Pak, they were running to the emergency room, incurring a $1,000 claim to get a $5 script. So that didn't make a lot of sense. And in a situation like this, when you have kids that are dependents that are away from school, it might not be a solution like a 24-hour nurse line, because a 24-hour nurse line, they can't write a prescription. So this was actually pre-COVID, before much of the world was actually in tune and adapt with telemedicine. So with this population, we implemented a telemedicine program. We did a communication campaign to these dependents over the age of 18 to use this tool as their first line of defense. So if they have a cough, they have strep, they have bronchitis, call telemedicine provider, tell them what's going on, and they can send a script to the pharmacy. So now you can incur, a $40 claim through telemedicine. However, the employer wants to cost share it. But we're keeping people out of the emergency room. In that same population, in some instances, we actually went to the point of doing three-way calling with our nurses and that dependent to get them matched up with a physician in the area that was accepting new patients. So same cost driver behind that, but really two different shiny toys to really target that cost driver. And that decision was really made based upon collaboration and being able to see into the claims data that a traditional self-funded plan should provide. So the same, but also unique in their own right. Another example I think that's kind of funny is everybody talks about these shiny new toys, but did anyone ever think that a water cooler, might be a shiny new toy to solve a problem on their health plan? So we had a client that was a construction company. We saw a lot of utilization of chiropractic. This didn't really come as a surprise right off the bat, because naturally thinking, you have construction workers probably lifting things wrong, but a very physical and laborious job throughout the course of the day. To see many of them end up at a chiropractor really didn't come as much of a surprise. But what we did identify is that none of these people were getting better. So after working with some of our clinicians at Nova, working with the consultants and digging down deeper into the data, we actually began to find out that a lot of this lower back pain was actually as a result of kidney issues and kidney stones due to dehydration. So in this situation, we worked with the employer to increase the amount of dehydration, or increase the amount of hydration stations across their work sites. So, hot summers, people working hard, people sweating, and not staying hydrated was really the root cause of what was driving, the lower back pain. So I always think that one's kind of funny, but unique in its own way, as, that's one of those shiny new toys that you'd never think of, but through data and collaboration, you find a solution that really doesn't cost much money. Another popular buzzword, that we hear about a lot in the industry really is reference-based pricing, and I think that there's a lot of money to be saved in reference-based pricing. We've seen it with our clients, but it's not really a perfect fit for everything. I really think that there needs to be a strategy around it. I am a firm believer in the crawl, walk, run approach. If I was bringing on a fully insured employer group and they were looking for a way to save money, I don't think that jumping to a self-funded reference-based pricing plan in year one to save that money is going to be a good approach. I think education is always foremost and key, and basically having a game plan years 1, years 2, years 3, years 4. One of the examples that always, jumps off the charts for me is, we had an employer group that was self-funded with the BUCAs for a number of years. When we brought them on, they had a $4,000 single, $8,000 family deductible. It's to my understanding that the previous broker was using the employee deductibles as a way to manage the fully insured increases for a handful of years. I'm sure we've all seen it. And in reviewing the data after some time, we found that the result of the increases in the claim costs was really due to inpatient stays as a result of members avoiding care. And the reason that people were avoiding care was the average person with a family doesn't have $8,000 to cover a deductible after paying rent, the utilities, a car payment, putting clothes on the children, putting food on the table, probably having a portion of their take-home pay going towards their employee contribution towards the health insurance. So the $8,000 deductible is a lot that people just can't absorb to see specialists to manage their chronic conditions or to take maintenance meds to manage their chronic conditions. So I think we can all probably relate that these fully insured plans and even into the self-funded plans over the last 10 years, these deductibles have continually gone up to help control the cost for the employer. With this population, in identifying that really the claim drivers were inpatient stays due to people not taking care of this themselves, we actually worked with a local direct primary care clinic. We began to pay a capitated rate where members could go for a list of services and prescriptions at no out-of-pocket. At first we saw a little bit of an uptick in fixed costs because we're obviously paying that capitated rate now for these members to go into those clinics for those services. But I can tell you that if we can avoid one emergency room visit with just one member, it will cover the capitated rate for the family for the entire year. So even if they don't utilize it every single day, if they just go there once instead of the emergency room, it pays dividends. And we also ended up getting rid of the PPO network. And the reason for that is many of them limit the ability to steer within network walls. So some of your more national PPOs, you have to have a plan design, treat every provider the same. But when we're partnering with a DPC clinic, we want to be able to create a plan design where in this instance, there's no out-of-pocket to the member and steer them into those facilities for those services at no out-of-pocket. So first thing we did is we got rid of the PPO network. And then following that, we actually moved to a reference-based pricing model. So members still had the choice to go wherever they wanted to go. They would still have to be subject to that deductible. So most members in thinking and with proper communication to them, why wouldn't they go to the clinic for those services? It's in their backyard. It's more of a rural area as well. So there's not thousands of providers that you can go to. We gave the members the ability to go outside of that clinic, but they would still be subject to that deductible. So with that plan design differential, we were steering utilization into those clinics and obviously seeing improvement in outcomes. Also on the facilities, we were doing reference-based pricing as well. This is a 2-hospital system town. And we have since identified that one hospital system is playing much nicer than the other. So another buzzword in our industry we often hear of is direct contracting. And, a lot of people would say, well, why don't you direct contract with that hospital that's doing nice and, get rid of the reference-based pricing? Well, I can tell you that if a hospital is accepting a reference-based pricing reimbursement at 140% of Medicare, they're never going to do a direct contract at 140% of Medicare because they're never going to sign off on that rate. If they were to do a direct contract, they'd probably do 180% of Medicare. So in this solution, we're going to leave the reference-based pricing in place. And really the evolution of this whole program is now, next time we have a plan year renewal, we're actually going to create the plan design where we're going to eliminate the deductible for the members to drive into the facilities that are playing nice. So we will have reference-based pricing on all of the facilities, but we will have a plan design that steers into the DPC clinic as well as the hospital system that's playing nice. So I think that that is a good example of kind of, you know, our crawl, walk, run approach. I don't think making drastic steps, you know, in year one is the ideal situation. It creates for a lot of noise, a lot of confusion. And, you know, the other thing with DPC too is it's a great buzzword. Everybody talks about it, but, you know, how is it helping the members and how is it helping the plan? You know, I have talked to many DPC locations across the country. A lot of them just focus on employer groups, and many of those employer groups have fully insured plans. Now, if I'm an employer and I'm paying a capitated rate to have this benefit for a direct primary care clinic in my employee's backyard, you know, that's great for the membership, because now they can go to those clinics for services A through L at no out of pocket, which obviously saves the members money. But how is it helping you, Mr. Employer? You're paying fully insured rates. These fully insured carriers do not give you any credit on their rates because you're basically carving utilization out of the fully insured plan and you're paying it through this capitated rate. So you're basically putting more money into the fully insured carriers' pockets because they're not paying as many claims. And thank you, Mr. Employer, the carrier will say, for paying this capitated rate for all your members to go to this unique DPC solution. So, you know, we've recently partnered with an organization rolling out a plan called the Alchemy Health Plan across the state of Colorado. And really, it's a great collaboration. It started with me talking to somebody at a DPC clinic, basically sharing that same story, that there's not any carriers that will partner with us. The DPC's clinics, all of their clients were employer groups, and there wasn't a single health plan that would really partner with them and give them credit to their rates based upon members going into those locations. So we're excited about that opportunity and working with a clinic across Colorado where they have 23 locations. We will pay a capitated rate, and we've worked out a contract with a large hospital system called Centura Health, where these people will be, have the ability to go to the Centura Health narrow network. But at the end of the day, these are self-funded with a captive. You know, some of these employers might be smaller, so the thought of self-funding, you know, might be frightening. You know, people are concerned about cash flow. People are concerned about lasers. Well, when you get into a captive, which is another buzzword in the industry, you know, you start to share risk with like-minded employers. So in this situation, we're going to have employers that are going to benefit from paying that capitated rate and steering utilization into those DPC clinics. They are going to benefit from steering all of their membership into one health system who is going to give them a more competitive rate than a PPO network. So it's a little bit more narrow, but I think in these times, employers who are first and foremost all probably crunched for cash flow right now, right? Also, I think that 10 years ago, employers wanted to have employees to have access to every single provider or facility across the country. But there's really no way to control costs when you're doing that. So really trying to provide high quality care at an appropriate price for the membership is really taken priority versus allowing just people to go anywhere, having no control. So in this situation where you have DPC for these members to go to for all their primary care and specialty needs, layering it with a very strong hospital system, and then sharing risk with other like-minded employers that are doing the same thing that will benefit from, you know, the savings on the claims. But if one member of an employer group, you know, needs a transplant and needs a $350,000 laser from a traditional stop-loss carrier, now they're all going to run basically together, you know. So if you have 20 groups with 10,000 employee lives and there's a laser for $350,000 transplant, you know, now we're going to spread that across all of the employer groups, but hopefully the dollars that we're saving in the captive from all of these cost management strategies, between DPC and the narrow networks will help absorb that as well. So, those are just a little bit, some of the examples I like to use on how different problems can have different types of solutions. And really it is collaborating with the consultant, the employer, understanding the region, the industry, the demographic. There's a lot of really strong apps out there now, right? There's different apps you can pull up to find out where you can go for, more cost-effective pharmacy prescription, But if you have a population that isn't going to engage with mobile technology, what is the point of putting in that type of solution? There might be a bit better way to target that problem. So I think in closing, really, I think it's just important for everyone when evaluating, a potential solution, or a shiny new toy to your client, make that decision that will really best produce results for them. Solutions that are trending in the industry, aren't always the best solution for every population or employer group. So I think everyone here really is probably on this call today, to try to add value to their clients. And I think the first place that we can really all add value is just beginning to understand them, and understanding what is in the toolbox, as Jim would say, of shiny new toys that can help, improve not only the outcomes, but the cost as well for the employer. So with that being said, I think I'm going to hand it over to Sean for some questions.
Great, thanks, Todd. So the first question coming in, how do you determine who the best vendor partners are?
Teresa, you want to take that one, coming from the product side?
Teresa, looks like you're on mute.
Can you hear me now?
Yep.
Okay. I unmuted in one place, not the other. I've got two audio things going on here because of the problems earlier. So I am the product manager, so vendor review is one of the functions of my job, and I am a certified health value purchaser through the Validation Institute. So just a quick plug for that program. That is actually really great if you do not have feel like you have a strong toolkit in evaluating vendors. That's a really good place to start to really understand the return on investment from the different vendors that you're talking to. So, every vendor out there will come to you with this promise that they're going to save you so much money and it's going to be so great, and you'd be a fool to not do it. And that may be true. They may be able to save you money. They may actually be able to provide really great, awesome services to you. But you need to look at your population and see if what they're providing will actually be useful for the population that you serve and that you cover. And, let's say that their claim is that they will save you $500 for every member that signs up for their program. Well, that could be based off of a national average. But if you have a regional population, that is probably not going to be what your savings are. So you can't really just take your population, multiply it by $500 and say, well, we're going to save so much money, we have to do this. Sometimes you do have to adjust your expectations and realize that it is still valuable to move forward, but it may not be quite as promised from the vendor. You want to make sure that the services provided are quite as promised, but the return on investment, sometimes that's a little bit more where you have to dig deep on your internal data and do your own research instead of, taking the marketing materials and saying, well, we'll just multiply it by this. We'll take it to our chief financial officer and we're good to go. Sometimes you have to be a little bit more thoughtful in how you break down the return on investment. In fact, sometimes you may find that it costs you more money when you implement a solution. Maybe doing something will cost you a big investment in the first year, or maybe the first 2 years. But if you're looking 5 or 6 or 10 years down the road, that's when you'll really see a reduction in your costs. So you really have to look at it as what are your short-term costs, what are your short-term return on investment, and then what's your long-term strategy and long-term return. One thing that we also do at NOVA is we have a forum where our leadership team meets monthly to go over any potential vendors that we're looking at. Everyone in this industry, we get calls all the time. Oh, we want to show you a quick demo. You go to a conference, back when we went to conferences. Oh, we want to tell you all about this. It's the greatest thing. we take those in and we really take time to evaluate those. And then our leadership team goes through them and we figure out, where do we see needs? Where do we have gaps that we want to fill? And then try and figure out where there's a match, and if there is a match now or maybe in the future. So, we really look at it as a comprehensive program. Vendors are really important in the self-funded industry. And so we take all the ones that we review really seriously to make sure that they are providing value, that they're providing what services they promise to provide, and that is really what our clients want.
Great, thank you. And what engagement and communication methods have been most effective during the pandemic?
I think that broke up a little bit halfway through the question.
Oh, apologies, let me read that again. What engagement and communication methods have been most effective during the pandemic?
Well, webinars have certainly been very helpful as we've been doing outreach to, the broker and employer community. We have an excellent communications team that does a lot of outreach, whether it's through emails or through LinkedIn. We actually have a really robust LinkedIn page. So if you don't follow us already, make sure you go on and follow that. We've always got all sorts of tools and resources that are out there. Todd, I know you do a lot more of the direct communication with a lot of the groups. I don't know if there's anything you found that's been more successful, but also our customer service center has been fully operational without missing a beat since the day that, we started to lock down, which was in the middle of March. And we have a really awesome customer service team that is very responsive to the needs of our members. So that's really gone forward without a hitch.
Yeah, and to piggyback on that, we've worked with a lot of our partners to, not everyone was a firm believer in, say, something like telemedicine a handful of years ago. So, with the whole pandemic and everything, that's obviously something that we worked with our employer groups that it made sense for them to implement that, because the last thing that we wanted was for people to avoid care during that time and end up, in some sort of chronic or catastrophic situation within the walls of a hospital. But in developing those strategies, but then also working with our communications teams to develop collateral that the employer groups could then push out to their members. Obviously in some instances we can do direct communication to memberships as well. But as Teresa kind of mentioned early on, sometimes, it's tough to engage with people if they don't understand why you're engaging with them. She touched on that when we were doing the case management type stuff. And once we would actually send a communication of a letter, we would have much higher success rate of engaging with these people over the phone. So we would really just supply a lot of our employer partners with the ammo to push it out to their associates and members on the plan, as I think a lot of people can sometimes be much more responsive to their employers than they would be from their health plan.
I can add to that too. I think in addition, as Teresa mentioned, we've had a strong work from home environment even before the pandemic hit. So that was a real positive, where we were able to transition pretty seamlessly. And then the client services organization that we have, the strong relationships, again, that they build and the partnerships that they make with each one of our clients really keeps that strong relationship going through the technology that we employ. So that's been very, beneficial during this time also.
Got it. And a question for the panel about data. Could you elaborate on the data collection and analysis process, and what are some of the data sources?
Well, the richest source of data is actually from the clients themselves. So that would come directly from the claims experiences that we see. But, when we're starting with a new group that we haven't worked with before, we have this connected company model where we take time to really get to know where the group, where they are, what they're, what county they're in, what the population is like, what the demographics of the employer group is like. We consider all of our employer groups, all of our clients, an extension of us. So we want to know them as well as we would know any of our internal associates, any of our internal company. We just treat it like one big ecosystem, one big part of the Nova family. So we really dive in to understand all the things that, maybe none of us have ever been to, Seattle, Washington, or had business there, but if we have clients there, we make sure we know it as well as we know our home base in Western New York. And so data starts there with understanding the community that our people live in. What are the challenges of that community? And it expands to once they come on board with us, what's their claims experience? What are their health needs? Where are their gaps? So, you know, a lot of Todd's examples were showing exactly that, looking at what is coming in and then analyzing it to find out where we can be the most useful to the people that we serve.
Got it. And how do you make recommendations when there's no data available for the members?
So, I mean, you want to take that, Teresa? No,
go ahead, Todd.
No, so I mean, honestly, so when there's no data available, obviously it's, you know, much less, I guess, analytical, I guess, per se. It's more conversational. You know, it's understanding the industry, it's understanding the culture, the employer group, the region of the country. You know, I've talked about, you know, a bunch of different strategies, you know, and I always use that crawl, walk, run approach with everything. But, you know, there's just certain part of the country, you know, where say a reference-based pricing solution, you know, won't make sense. You know, if I were to take a look at an employer group and the average age was 60 versus the average age of 30, you know, right there, that tells me that, you know, maybe an engagement tool on my phone would probably be more effective with the 30-year-old IT workers, let's say. You know, so I think the consultants really play a big role in that part because they truly know their clients better than us. You know, they can kind of bring the story to us. They might have ideas, we might have ideas that they never thought of, and vice versa. So I think that's really where the collaboration piece comes in most. You know, we have clients all across the country. We have associates all across the country, but we're not an expert in every backyard. And we'll never say that we are. So as we, you know, grow into a certain area, you know, we obviously learn more about the people, the culture of the region, but it's really all a process of evolution.
Got it. How does Nova coordinate with brokers and any other vendors that the broker might want to bring to the arrangement with an employer?
Yeah, so I mean, really, we coordinate with brokers. I mean, we're always here to partner with them. We're always here to listen, you know, but we've pushed back on solutions that they want to bring to the table. You know, there's maybe experiences that we may have already had with that vendor. You know, a lot of things look good on sell sheets and collateral, but, you know, not everybody has always had the opportunity to have experience with them. You know, we have great relationships with TPAs across the country. You know, I think that every TPA there's more than enough opportunity for all of us to do well. Some people might think that we are competitors, but I really think that we're also collaborators. You know, we often discuss what's working for them, what's not working. You know, if a consultant is adamant, you know, on bringing in some sort of solution, you know, we have to evaluate, you know, the type of lift it might be for Nova. First and foremost, you know, oftentimes it might be a solution that we could bring to other clients as well, you know, so we welcome those discussions. But, you know, really it's just kind of peeling back the onion, you know, understanding the purpose of bringing it in and how really it's going to affect the member, you know, how it's going to support the Nova brand. I mean, that's also important as well. You know, sometimes we have, you know, I've had brokers bring in reference-based pricing programs, and, you know, it comes to find out maybe the client really didn't know what they were getting into. You know, they heard that they could save 20% and they jumped right into it. And that goes back to supporting my crawl, walk, run theory. You know, if you're a fully insured plan of 150 employees, I wouldn't jump self-funding to reference-based pricing the next year. You know, these people might be on an Aetna network today where they can go anywhere, and now they're going to do reference-based pricing. You know, I don't know what the member is going to say. I don't really like this Nova insurance, you know. So I think that really it's all about, you know, going back to that buzzword of collaboration, but just discussing it and having more of a game plan than just flipping on all these switches at once.
Got it. It's interesting you mentioned reference-based pricing. The question we have here, do you direct contract with specialists that do procedures with ASCs, and how does that come into play to avoid RBP friction and reduce facility fees from hospitals?
Yeah, so I mean, that's really, kind of like a regional approach as well. We have relationships where we might be doing reference-based pricing with some facilities, but we'll be direct contracting with a specialist in that backyard. Kind of to go back what I said too, though, direct contracting typically is something that we do when we are having issues with reference-based pricing. And this is just my background. If somebody has a relationship and there's somebody that's already, ready to play ball and the employer's happy with them, we're happy to build that out and integrate it. A lot of times people instantly say, let's do a direct contract, let's do a direct contract. But so much of the reference-based pricing across the country is flying just under the radar and not really being addressed by the hospital systems, or maybe they don't care because they're getting paid quicker. Most of our reference-based pricing programs, we're eliminating deductibles on, so the facility's not trying to chase down a deductible, so they'll accept payment in full. So in those instances, if we're capturing 140% of Medicare, we don't really go towards the direct contract because no facility is going to put 140% of Medicare down on paper as a direct deal. They'll probably be more around like between 170 and 200, which still is better than a PPO network. So we've done it ourselves with direct contracting. It's nothing that I would say is probably our area of expertise. We're not coming here today saying that we're the lead negotiators and negotiating rates with facilities. We work with some other third parties that we can maybe leverage their contracts. Other times we might work with them to say, hey, ABC specialist, we have 2,000 employees here. We're having issues, getting into a specialty of your nature. Would you be open to doing a deal with us if we're going to steer these 2,000 employees in your backyard into your clinic? So a lot of times we'll rely on vendors for that. Or if a client comes to us, whether it be, our clients can be everything from another TPA, a health plan, a self-funded employer. If they already have something established, we're more than happy to support it or duplicate it. So I think that kind of answered the question.
Got it. And
we do also,
go ahead.
One small thing, we do also have access to centers of excellence for highly specialized disease states. So we do have that as a supplement to reference-based pricing in a lot of cases.
Yeah, so she was cutting out a little bit, but I think what she was touching on is we have relationships with multiple centers of excellence programs across the country, so common things, well, hopefully not common, but, say for transplants, if we were to see a transplant request come in, we wouldn't necessarily just go with like the PPO network that the person's involved in. We would take a step back. We would take a look at all the centers of excellence programs that we have contracts with, from LifeSource, LifeTrack, Optum, maybe 6 Degrees, and really evaluate all of those parties and determine what is the best area where this member resides to have this procedure done, right? So who's got the best outcomes? And then work with those third-party centers of excellence programs to see who has the best contracted rate that we could leverage.
Got it. And then just sticking with direct contracting, and then we'll transition to some other questions. What should an employer look for when directly contracting with a provider? What recommendations do you have?
Well, I mean, I would first and foremost say that, quality, there's a lot of technology out there today that reflects quality. I always use my mom as the example that, there's just a generation of people, and it's the majority of healthcare consumers that don't have an understanding of that they can go find quality, and I always use the example back to my dad when he had his knee replaced. So my dad had his knee replaced 3 years ago, and he just went to the doctor that his primary care directed him to, and my mom didn't do any research if this guy's done 1 or 5,000. But she'll spend 3 years, researching a vacuum cleaner purchase. So I think it's really holding our membership's hands and, identifying, who is higher quality. Everybody talks about direct contracting, is it one single provider that you want to direct contract with? Like, why is that? Is it because you want to steer people that direction? Or is it, an entire organization of providers where you're going to get access to providers, specialists, and many other needs? And it would almost become, like a direct primary care arrangement with a group of physicians. So You know, that is something that, you know, we could help support, whether we took the lead on it on ourselves or, you know, brought in a third party or leveraged another contract. But yeah, I mean, first and foremost, I think that we would want to do research on quality. You know, the cheapest isn't always the best. I think that there's kind of a happy medium there, you know, and the most expensive isn't always the best. So I think you want to try and find the best of both those worlds. I think it's through collaboration and conversation and showing people that want to direct contract, sharing some of these transparency tools that are out there, you know, and kind of doing an evaluation of this, whether this makes sense or not.
Got it. And to that point with transparency, what recommendations do you have for employers to strengthen transparency and avoid overspending? And how would you say they can engage their employees to really make the right decisions?
Yeah, so I mean, you know, the national PPO networks are probably something that you can't use when trying to steer. That is one of the things that I think a lot of the self-funded employers are getting away from. You know, 10 years ago, you had Cigna and Aetna started leasing their networks out, and everybody wanted to have access to every single provider across the country. Well, rule number one is really not allowing to steer within their network. So they don't want you, you know, steering a member towards location A over location B. And the majority of the reasons behind steerage, you know, would be quality. So, you know, one of the things that I would probably do, step one, is get into maybe a more regional network approach if you don't want to go all the way to reference-based pricing, but then leveraging some tools. I know 6 Degrees Health has a great tool called MediV, where you can pretty much type in, you know, a service and drill down by county, zip code, and take a look at all of the providers of that service, you know, in a certain zip code per se, and you get an idea of who has the highest quality. And that quality score is typically, you know, derived out of readmissions. You know, so I think that, you know, being able to share those tools and have those conversations with members, and, you know, say a pre-authorization comes in for the type of surgery, you know, and we can identify that there might be a more cost-effective place to go, you know, then it might be a role for one of our nurses or a care navigator to engage with, you know, that member who is seeking care, and just educating them, you know, letting them know that, you know, you're looking to get your knee replaced by somebody that did it 5 times over the last year. 3 of those people are readmitted. Did you know you could go down the road to ABC provider, and these people have done it 5,000 times, have had 5 readmissions? You know, where would you rather go? So I think that it's really that engagement and that conversation, you know, that will help kind of bring transparency and light to, you know, the consumers of the healthcare system. You know, there are some apps and some tools out there, you know, which also might be appropriate. But again, you know, that's for the right demographic. That's for the right, you know, population that you're trying to communicate with.
Got it. So coming up on the hour, so we'll have time for one more question, then we'll move to closing thoughts. If a client had a preferred vendor partner that you don't support or you wouldn't recommend, do you still work with them, or would you try to talk the client out of it?
I think we would probably have a conversation and let them know our concerns. You know, we've gone down that road before. You know, there's certain vendors out there, to be 100% transparent, because that's what we are, that, you know, I don't always feel are, you know, doing everything, you know, in the best interest of the client. Sometimes there's a lot of gray areas. A lot of times vendors don't understand what the meaning of an SPD is and how an SPD truly needs to be, you know, very, very bulletproof. A stop loss carrier is going to reimburse 100% based on that SPD. So a lot of times there's vendors that kind of want to carve things slightly out of the SPD in certain instances. So, I mean, at the end of the day, you know, it's a self-funded plan. You know, the employer truly owns the plan. But, you know, it's our job, you know, as their administrator and as their, you know, steward, to just make them aware of, you know, some of the issues or gray areas that, you know, some vendor might be bringing them into.
Great. And I'd like to move now to Jim. Jim, any closing thoughts?
Thanks, John. I guess maybe just a couple. I think, you know, first and foremost, thank you very much for the opportunity to present today, and a thank you to Validation Institute and World Congress. And I hope today we're able to at least show how, you know, we kind of frame up the strategy and look at things not in more of a boilerplate or cookie cutter approach, that really it's about understanding the needs and then figuring out what's the best solution, given the best capabilities that we have access to today. So hopefully we've been able to provide some good insight to that, and also some good examples of some of the things that we've been doing here at NOVA. And with that too, I'd like to just extend that if there are any other questions or any follow-up that anyone would like to reconnect after this, you can find any of us on LinkedIn, and also feel free to reach out at asknova@novahealthcare.com. And thank you again for the opportunity.
Awesome. Well, thank you, Jim, Todd, and Teresa. Thank you for all the folks who signed up and joined us today. And thank you to NOVA for making today's session possible. And it was definitely a great discussion. Just a reminder, folks, the webinar has been recorded. You'll receive an email with a link to the video so that you can view it again. And if you'd like to access any additional webinars or get information on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again to everyone for joining us today. Have a great day. And this now concludes today's discussion.